Alright, here's your continuation for cardiac dysrhythmias. I believe we stopped here last week. We discussed both sinus brady and sinus tach, which are the two main sinus dysrhythmias. Again, the only thing wrong with these two are the rate, but otherwise, as we discussed last week, there is otherwise normal measurements for all the waves and complexes. Again, the only thing wrong here is the rate. In sinus brady, the rate is less than 60, and then for sinus tach, the rate is over 100. And we also discussed that the treatment will depend if the patient is symptomatic. So as stated here, sinus brady, if symptomatic, is treated with atropine 0.5 milligrams IV push. But otherwise, if there's no symptoms, then we just identify and treat the cause, which should eliminate the sinus brady. And then for sinus tach, it's the same thing. If the patient is symptomatic, then we treat it. We give them beta blockers. Then you have a summary of the medications here, table 29-1. This will cover most of the dysrhythmias under chapter 29. Of course, these causes right here are later in the chapter, so please refer back to table 29-1 for the medications. Okay, for instance, when we get to SBT later, now the SBT is also discussed under that section, but always refer back to table 29-1 for the exam questions. Okay, so this is how the author organized the chapter, so we'll just have to work with it. So she put the medications in this table, so you're gonna have to go back to this section of the chapter when studying. And as I described last week, exam questions will be on for rhythm questions. So I said you'll be asked to recognize, meaning I'll just give you the strip. It's not like there's 20 strips on the textbook. There are no, probably close to 20, but I won't test you on any strip that's not found on the textbook. Okay, all strips on exam will strictly be taken from your textbook. Next is the causes of the particular dysrhythmia. Then next are the signs and symptoms, if any. But you know already, we discussed last week, the signs and symptoms are really consistent with the either decreased cardiac output, which is in most cases the patients presenting signs and symptoms, or whenever there is congestion, there may be evidence of clotting, because you know what blood does. Whenever they're congested anywhere, they form blood clots. This is usually for basic two rhythms that cause clotting are AFib and A flutter, which we will discuss today. And finally, interventions. And as we discussed last week, if symptomatic, the patients will be treated with pharmacologic interventions, but otherwise, remember that there are nursing interventions, which usually involves applying oxygen, increasing venous return, or other nursing interventions that increase cardiac output. Then of course, these are dysrhythmias, so most of the time we will be giving pharmacologic interventions, which are your drug therapy. Again, majority of this is in table 29-1 unless otherwise also mentioned in the section of the chapter. Now don't forget that the causes you also treat the causes. Okay, so this meaning some interventions might not be pharmacologic. You don't go straight for pharmacologic. Some of the interventions will also be to treat the causes, right? So please bear these in mind as you study the chapter. Okay, let's go now to the first group, which let's do a PAC first. Okay, let's do sinus dysrhythmias first. Oh no, we did the sinus, which are sinus brady and sinus tach. What I mean is atrial dysrhythmias. Okay, so we have these are the atrial dysrhythmias. We have PACs, AFib, A flutter, and the last one is sinus tachycardia. It's actually no SVT, sorry, which is supraventricular tachycardia. This is still under atrial dysrhythmias. Okay, let's start with PACs. Stated here, these are harmless dysrhythmias. Usually they appear in a normal sinus rhythm. You can easily identify a PAC because it looks different from a regular P wave. And it's also easy to identify because there's always a compensatory pause that follows the PAC. Okay, so the purpose of the compensatory pause, as mentioned here, is to allow the conduction system to reset. Causes are usually, believe it or not, coffee is a very common cause of the PAC. For you coffee drinkers, you may have experienced this already, wherein your heart skips a beat because it technically did because of this compensatory pause mentioned here. This pause can be felt, but otherwise the patient will have no symptoms really. Other causes besides coffee are infections, disease toxicity, and coronary artery disease. Don't also forget hypoxia. By the way, throughout the chapter there is a summary of the dysrhythmias, giving you all these information here, of course except the strip, because the strip is not on the table, but otherwise it tells you the signs and symptoms, the causes, the interventions, including the patient teaching. Okay, so here is your first summary. So this one is a summary of your sinus dysrhythmias. Okay, so we have here your signs and symptoms. So again, sinus dysrhythmias typically are harmless unless the patient has symptoms, of course, meaning if they're severe. So these are your they divided it whether or not the patient has symptoms. So if there are no symptoms, then these are your nursing actions here. Here's the client teaching. And for symptomatic, you have here symptomatic bradycardia. Here is now your atropine and pacing if necessary. And then for sinus tach, vagal maneuvers, carotid massage is only done by a physician. Okay, don't go around massaging your patient's carotids. We're not doctors. Or the doctor may just order beta blockers, and as already mentioned, treating the causes or eliminating the causes will eliminate the dysrhythmia also. Here's the picture of your PAC. Here, otherwise, you clearly see a if you grab your poor man's caliper, the piece of paper, if you measure this from this, and then also this P to this P, and then this P to this P, these are all regular. Okay, the rhythm is regular except this one. So obviously this one, we estimate the P is supposed to occur right around here, right here, but then this P occurred too soon. But as you can see, it looks different from your regular P's. These are your regular P's, and this one is a little bit sharper and shorter and smaller. Okay, and then what follows, as described earlier here as the compensatory pause, well, here is your compensatory pause on the rhythm. Okay, so this here is your obvious compensatory pause. Then after that, the heart rhythm resets. So here you're back to your regular underlying rhythm, which is usually normal sinus rhythm. PACs again usually don't need treatment. The treatment again is the cause. So as we identified here, the causes of PACs are what? These are the identified causes or the known causes of PAC. So locate them. If the patient has any of those causes, then eliminate them. They should eliminate the PAC. Again, I'd like to reiterate that PACs are not really harmful unless they occur more frequently. Then that could signal, it will serve as a warning sign that there may be more serious dysrhythmias coming. But PACs by themselves are usually harmless. So again, your only action here is to identify and eliminate the cause. AFib, as I mentioned last week, age is the most common risk factor for dysrhythmias, and for most elderly, this will account for most of the people who have dysrhythmias. Okay, this is the cause. As stated here, AFib is often seen in people over 65 and occurs in about half of patients who undergo surgery. Okay, so this is pretty common. This is AFib. You have different variations. The label here is there. It is controlled. So here, look at your ventricular rate. Okay, it is controlled. This will be one of the proofs that your AV node, as we discussed last week, the AV node can serve as a gatekeeper, meaning we have 3 pacemakers, correct? So we said last week that there are 3 pacemakers. So we have this is the SA node. Then you have the AV node, which is your secondary pacemaker. And then finally you have the left and right bundle branches and the Purkinje fibers, which supply the ventricles. Okay, so the SA node fires, which forms your P wave. So obviously in this rhythm right here, since there are no P waves, then that means this can't be sinus rhythm, because again the rhythm that has a P wave means that the electrical impulse originated from the SA node. So clearly here, as defined, there are other sources of the electrical impulse, but definitely it's not the SA node. Where are they coming from? Well, it's not easy to tell unless we submit the patient for an EPS study. That will be one of the non-pharmacologic interventions for AFib. We'll discuss that shortly. So this one is a more rapid response. So here in figure A, the AV node is doing its job, meaning it's not responding to these fibrillatory waves here. In B, it's the AV node is not doing a very good job because it is responding to some of the fibrillatory waves. That's why the heart rate increased. And here, Definitely the heart rate is uncontrolled. So this type of AFib is called AFib with RVR, or rapid ventricular response. So as we discussed last week, the more QRSs you pack into a 6-second strip, then the narrower the ventricular filling time. The shorter the ventricular filling time. So therefore here, the obviously the ventricles are beating so fast but are not producing enough cardiac output. Okay, so they are wasting oxygen, consuming a lot of oxygen, but is not producing an equal or a commit even a considerable amount of cardiac output. Okay, it's just consuming a lot of energy but is not producing enough cardiac output. So the goal, of course, here in AFib is to control the ventricular response, meaning as long as the heart rate remains low, the ventricular rate specifically remains low, then the patient should have enough cardiac output to sustain life. These are the most common causes of AFib. As you can see, it basically are conditions that lead to heart failure, which means in heart failure, if you remember, causes blood to stagnate within any of the heart chambers. Either they stay in the atria or in the ventricles, which is what these conditions do. Like cardiomyopathy leads to heart failure. We just finished pericarditis last week. This will lead to pleural effusion as well as cardiac tamponade, pulmonary disease, because this increases pulmonary hypertension, causes pulmonary hypertension, which will therefore cause heart failure, right-sided heart failure. Valvular disease, we just finished last week, which will also lead to heart failure and congestion. So again, most causes of AFib is any condition that leads to a congestion of blood in one or more chambers of the heart, thereby resulting in in irritability of the atria, causing these other sources of electrical impulses to fire other than the SA node. Most dangerous complications of AFib are two. One is loss of cardiac output. If this doesn't kill the patient, the other one will, which is clots. Clots here, of course, will either cause an MI, or more commonly, if it doesn't lead to a PE, then the patient will die from a stroke. So therefore, since these are our complications, our treatment therefore will be also targeting these two, meaning as you can see on the treatment here, one goal of treatment is to prevent these clots from forming. So that's why you have heparin and Coumadin. Okay, we go heparin first because heparin will give immediate anticoagulation, and then followed by warfarin. Okay, warfarin is used, as we already discussed last week, under valvular disorders. Unless the patient has a valve problem, then we can use NOACs. But remember, if the one of the causes here is valvular disease, so if it's caused by a valve disease, then of course our anticoagulant of choice is warfarin. So that's one goal of treatment. The other is to maintain cardiac output, because remember, there is loss of cardiac output here. So the treatment will focus on, meaning the other treatment will focus on controlling the rate, the ventricular rate, which of course will use beta blockers, calcium channel blockers, and the other is cardioversion. Okay. So there will be two tables under the atrial dysrhythmias later on below. Let me explain cardioversion. There are two forms of cardioversion. There is a chemical cardioversion, and there's also electrical cardioversion. And this is the indication for cardioversion. It'll be considered if um, there are no clots in the heart. And as stated here, cardioversion is not recommended if there are clots found inside the heart. In that case, we can consider the other procedure, which is ablation. I'll discuss ablation shortly. Now, going back to chemical cardioversion, these are the drugs used for chemical cardioversion. Either we use digoxin, beta blockers, or calcium channel blockers. Okay, these are the frequently used chemical for chemical cardioversion. Now, the electrical cardioversion is using a defibrillator. The defibrillator, which is the same machine we use to treat a patient with who goes into cardiac arrest. You know the here show you a picture. Okay, so this is you've probably seen this on the floor on the crash cart. So this is the defibrillator. Now you see a green button here. See if we can allow. Okay, right here. That's an on button, and there's a button right here called which says sync, SYNC. Now, if the sync button is off, which clearly here is not lit, this will function as a defibrillator, meaning this will, of course, discharge an electric shock, minimum 200 joules up to 360 joules of electricity. So again, if the sync button is off, this will function as a regular defibrillator. However, if this is used as an electrical cardioverter, the doctor or the nurse will make sure that the sync button is pressed, and then the machine becomes a cardioverter. In which case, unlike a defibrillator wherein the electric shock will be delivered randomly, when the sync button is pressed, the electric shock will only be delivered at the peak of an R wave right here. So therefore, it will sync with the patient's rhythm first, analyze it, and it will try to deliver the electric shock at the peak of an R wave. Doing that will usually cardiovert the patient, meaning the patient's rhythm goes back into a sinus rhythm in most cases. In either way, whether it's used as a defibrillator or a cardioverter, no, the rule is, of course, you still have to shout clear, so that nobody touches the patient. So that is alternate. Okay, so again, we have two ways to cardivert. Either we use chemical cardioversion, or the electrical cardioversion using this one. Another thing to remember is if we're doing cardioversion, you do need consent for this. The patient has to, or the family member must sign consent, unless of course there's an emergency. And the patient will also be given sedation, because unlike the defibrillator, wherein usually we use the defibrillator when the patient's in cardiac arrest already, meaning the patient's unconscious. In cardioversion, the patient is conscious. So imagine being given an electric shock while you're fully awake. That's scary. So the patient will have to be sedated, and before we do cardioversion. Okay, in case I forgot to mention that. The other option is catheter ablation. So let's say the patient does have blood clots found in the heart, so they can't do a cardioversion. They can do a catheter ablation. This one, before they do this in the cath lab, the patient will have to undergo an EPS. For an ablation, patient has to have an EPS. EPS is electrophysiologic study. This is done by a cardiologist. So remember in AFib, the cause we said was there are other sources of the electrical impulse other than the SA node, meaning these electrical impulses are coming from areas within the atria other than the SA node. So we have to find those sources, and the only way to find that is through an EPS study. So after the EPS study, when the cardiologist finds where those electrical impulses are coming from, then they'll take the patient to the cath lab, and then they will literally burn those sources of the electrical impulses. So they will burn them with a laser to prevent further conduction through that area. Okay, so that's another option. Both of these, of course, are scheduled. Okay, and then the doctors decide whether or not the patient is a candidate for these procedures. Atrial flutter. So let's begin with what is it? So you have a rhythm here. This is a flutter. This is described as a sawtooth. Unlike AFib, this looks more regular. So these are two variations of a flutter. This one has a higher heart rate. This one has a lower and actually a variable conduction rate. Okay, in either case, this is very similar to AFib. These are your causes. Can occur after an MI or valve disease, COPD, or thyroid hyperthyroidism. And it can also be caused by digoxin. This will be one of the many dysrhythmias attributed to digoxin. The treatment, of course, it's similar to AFib, wherein your concern is the loss of cardiac output and also the clot formation, because really it has the same effect, whether it's fibrillating, the atria fibrillating, not contracting. So here obviously there are no normal P waves here. These are called flutter waves. Okay, same thing for the B picture. Okay, there are no P waves there. So therefore, these things are not coming from the SA node. So it has compared again to a AFib, this one has a sawtooth pattern. So of course the treatment will involve also treating the cause. So if it's caused by an MI, then we treat the MI. Other than that, again, this resembles the AFib. So we treat the patient's causes, and then we support cardiac output, making sure the patient has adequate cardiac output, control the ventricular rate. And of course, the patient is, just like in AFib, are prone to forming clots, so they will also be put on anticoagulants. So here, the only thing difference here, there's no digoxin used. Oh, actually, digoxin is still used for AFib. I mean A-flutter. Sorry about that. Here we have cardioversion again, so similar to AFib. However, as stated here, the patient is not treated with it right away. Okay, it's not the first line choice for atrial flutter. And that's it. The last atrial dysrhythmia is a supraventricular tachycardia. It's A flutter. Okay, so SVT is this. If you compare this with sinus tachycardia, it's really very similar. But the heart rate is, of course, way higher compared to sinus tachycardia. And unlike sinus tach, wherein there are normal P waves and the PR interval is normal, all the other measurements are normal. This one is no longer normal. Here you can't really um, discern your P waves. Okay, and then the heart rate is just ridiculously high. So there are two types of SVT, either regular SVT, which is figure A, and then SVT can also be paroxysmal. Paroxysmal means sudden onset and also sudden cessation, meaning the condition suddenly comes on without a warning and also spontaneously resolves with no intervention. That's what paroxysmal means. So as you can see here, there's a normal sinus rhythm for these, and then suddenly the patient goes into SVT. Okay, so this is called paroxysmal. It suddenly just and then it will also, if we had another 6-second strip, this will show that this will just stop suddenly, then go back to sinus rhythm, and then this will occur again. So that is PSVT. And figure A is your regular sustained SVT. Okay, let's go to the causes. Okay, SVT, the causes are as stated here. SVTs can be considered an umbrella term to capture one of 5 narrow complex tachycardia rhythms. So since these are the other atrial dysrhythmias, that means the causes of SVT are similar to those causing the other atrial dysrhythmias, namely AFib and AFlutter, right? So SVT, the causes are similar to those, and then the treatment, of course, will be depending on whichever one is causing it particularly. And just like in AFib, the patient may also be a candidate for cardioversion. There is one drug used for SVT, and that is adenosine. Let's go back to, where are we now? Okay, 548. Let me point you back to the drug chart, table 29-1. Okay, so here is SVT. This is the drug of choice. This is the first line treatment for SVT, okay, not cardioversion. Reason is it's readily available and most patients respond quickly to SVT. This is how it's given. Initial dose is always 6 milligrams, and this is given really fast. May be repeated in 1 to 2 minutes. This time the dose is now 12 milligrams. In either case, the patient, this thing must be given really fast. That's why 6 milligrams will probably be only 1 ml. So and the drug has a very short half-life, only a few seconds, less than 5 seconds half-life. So therefore, if you give this really slow, then the drug won't be effective. So that's why it's really given really fast. Here the dose is rapid IV push, and after you push it, it must be followed by another rapid push of 20 ml of saline. Okay, so the drug is pushed really fast, followed by another rapid push of 20 ml. That way the drug will reach the heart right away, because again the drug has a very short half-life. Please take note, the patient will only get 2 doses, so 1 6 and then 1 12 milligram. There are what is this? There are serious side effects of the drug, which is not mentioned here. Let's go back to 548. Oh, here it is. Okay. Now, the drug is expected to result in a short period of asystole, meaning as it restarts the heart after SVT, the patient will go into asystole. Now, this is expected. However, if the patient experiences a prolonged period of asystole, then you must have emergency equipment available at the bedside. So the crash cart will be at the bedside, because if the patient goes into a prolonged asystole, then management would be the same as how you would treat asystole, which is you give the patient epinephrine, or if needed, the patient will be given atropine or put on a pacemaker, a transcutaneous or a temporary pacemaker. Of course, this will not eliminate the need for CPR as well, because the patient is in asystole. But a short period of asystole is expected when you administer the medication. However, if it becomes prolonged, then you'll have to, that's why we have emergency equipment available at the bedside when we give this medication. And that is for SVT. Okay, in here, this is the summary for all your atrial dysrhythmias. Just like earlier, there was a summary for your sinus dysrhythmias. This one is for your atrial dysrhythmias. So it begins here with PACs, AFib, A flutter, then SVT. Right. So here's the adenosine, and this one again, don't forget, go back to table 29-1 for the dosing and frequency, and here's a safety alert for your adenosine. Right. Before I forget, let's go back to the table comparing cardioversion and defibrillation. So as I briefly described earlier, this is the same exact machine. Okay, here is your defibrillator cardioverter. This is the life pack, and this is the difference between the two. Obviously, the defibrillator is used only for two rhythms: VTAC, pulseless VTAC, and ventricular ventricular fibrillation. VTAC, there are two types of VTAC, which we'll discuss later under ventricular dysrhythmias. VTAC can be with a pulse or pulseless VTAC. If this is the case, a pulseless VTAC, and the patient is in VFib, then the patient will receive defibrillation. So again, this is an uncontrolled electrical discharge of energy anywhere during the cardiac cycle, meaning the electrical shock is delivered at any time randomly. As soon as you press the button on the paddles, then it will deliver the electric shock. Cardioversion, this is controlled, because if you, again, the key here is to press this sync button right here, and then the machine becomes a cardioverter, and now the machine won't uncontrollably fire the electrical shock. So the electric shock will be delivered only at the peak of an R wave right here, the peak of an R wave, and that will restart the heart, convert it back to a sinus rhythm. And this is the indication for cardioversion, which we just finished: AFib, A flutter, and SVT. We haven't done VTAC with a pulse yet, but since it's mentioned here, ventricular tachycardia yet, but we'll discuss that soon. And that's the end of your atrial dysrhythmias. Okay, let's take a break.